Welcome everyone. On behalf of the Association of State and Territorial Health Officials, also known as ASTHO, I would like to thank you for participating in today's webinar entitled Collaborative Partnership and Practices for Accreditation Preparation. Today's webinar is being recorded and you will receive the link to review the presentation upon its conclusion. My name is Denise Pavletic, and I am the Director of Public Health Systems Improvement here at ASTHO and will be moderating today's session. This webinar is the third in a series of webinars that ASTHO is hosting around the topic of accreditation and quality improvement. Today's webinar is brought to you through funding and partnership between ASTHO and the Centers for Disease Control and Prevention, Office for State, Tribal, Local, and Territorial Support. The content of this webinar are those of the authors and do not necessarily represent the official position of or endorsement by the Centers for Disease Control and Prevention. Today's objectives, the webinar objectives for today are: one, to provide you with a history and background on the importance of collaboration for accreditation, to review the FAB measures that involve collaboration, and then to provide you with 3 state case study examples that demonstrate collaboration for accreditation through systems improvements. At the conclusion of the webinar, you will be directed to a link to answer a few questions on how well we have met these objectives. And in the spirit of our own quality improvement, we very much value your feedback, so please take a few moments to complete the evaluation. We're very excited to bring you today's webinar, and we look forward to a robust question and answer session at the end of the presentations. So now I'm pleased to introduce our speakers, and this is in order of appearance. Our first presenter is Joya Kaufman. She's a Senior Analyst of Performance Improvement here at ASTHO. She provides technical assistance to state health agencies seeking guidance on applying for voluntary national accreditation from the Public Health Accreditation Board. Joya manages, develops, and contributes to various initiatives at the national level here at ASTHO. She received her Master's of Health Promotion Management from Marymount University and a Bachelor's of Science in Communication Sciences and Disorders from the University of Pittsburgh. Joya is certified as a Health Education Specialist by the National Commission for Health and Credentialing. Our second presenter is Shirley Orr. Shirley is a Robert Wood Johnson Foundation Executive Nurse Fellow and Public Health Consultant. Shirley currently provides consulting for clients, including Robert Wood Johnson Foundation, the Public Health Accreditation Board, the Association of State and Territorial Health Officials, state and local health departments, and the Wichita Business Coalition on Healthcare. She has her undergraduate and graduate degrees in nursing and health science administration from Wichita State University. And Shirley is licensed as an advanced practice registered nurse in Kansas and is certified as Nurse Executive Advanced Level through the American Nurses Credentialing Center. We have 2 presenters from the state of Wisconsin. The first will be Rebecca Cohen. She's currently the Performance Improvement Manager in the Wisconsin Department of Health Services in the Division of Public Health, Office of Policy and Practice Alignment. Rebecca also serves on the Maternal and Child Public Health Advisory Committee, the DHS Workplace Wellness Team, Reaching Through Barriers Committee, and the Disparities Task Force. Rebecca earned her Master's of Science from the University of Wisconsin in Milwaukee in Urban Policy Studies, and her Bachelor of Fine Arts degree is from the University of Wisconsin in Milwaukee. Our second Wisconsin presenter is Angela Nisgern. She's a director for the Northern Regional Office of the Office of Policy and Practice Alignment, Division of Public Health. In her current role, she provides leadership for public health system and program coordination at the local, regional, and state level. Angela earned her Bachelor of Science degree in Economics from the University of Wisconsin-Madison and a Master's of Public Health degree from Yale University. She is certified in public health by the National Board of Public Health Examiners. Our next presenter is Luann McNichols. She's the Assistant Director of the Office of Performance Improvement at the Minnesota Department of Health. She provides leadership, TA consultation, planning, support, and performance measurement working across the Minnesota Department of Health and in partnership with local health departments and tribes. In addition, Luann's responsibilities include serving as Accreditation Coordinator and as the Public Health Nursing Director. Luann has nursing degrees from the University of Iowa and Louisiana State University. And last but certainly not least, our final presenter is Natalie Palenko, and she's the Director of the New Jersey Department of Health, Office of Local Public Health, where she provides leadership to initiatives pertaining to public health infrastructure, quality improvement, emergency preparedness, and regional planning. She serves as a policy advisor on the development of state and local public health systems and works to enhance the state's collaborative relationships with New Jersey's local health officers, boards of health, public health association, and academic institutions. Natalie has her Master's in Social Work and Health Policy from the University of Toronto and a Bachelor of Arts degree in Psychology from Rutgers University. So without further dialogue, I'm going to turn it over to Joya and Shirley. Joya will be up first, so please go ahead.
Thank you, Denise. As Denise mentioned, my name is Joya Kaufman, and I am a Senior Analyst of Performance Improvement at ASTHO. In that capacity, I provide technical assistance and lead the development of various resources to assist state health agencies to prepare for accreditation and implement quality improvement. As you know, the name of this webinar is focused on collaborative partnerships and practices during the accreditation preparation process. And I just want to give a little bit of background as to why ASTHO has delved into this work of finding examples and identifying case studies of collaborations taking place in the field. So as Denise also mentioned, ASTHO is funded by the CDC to provide capacity building assistance to state and territorial health agencies through the National Public Health Improvement Initiative, also known as NIFI. This includes providing on-site workshops and developing tools and resources that assist states to prepare for FAB accreditation. Over the course of the time that we've been providing this TA, ASTHO has had several conversations with states about their activities and some of the challenges they have faced with meeting particular standards and measures. Based on those conversations, we've found that several states have sought guidance on some activities that are going on with their peers around engaging in collaborations and partnerships that aid the accreditation process. These types of activities are specifically mentioned in domains 1, 2, 4, 5, 8, 9, and 10. So given this feedback from the states in the field, ASTHO sought to identify these examples so that states have a frame of reference as to what they could be doing in their own states during their accreditation process. So other than the obvious answer, one might ask, why collaborate? It's clearly outlined in the FAB standards and measures, but there are also other benefits to collaborating and establishing partnerships during accreditation preparation. Some of those reasons include collaboration and partnerships increase efficiencies and resources. It promotes the sharing of knowledge. It improves partnerships and builds relationships. It encourages communication and transparency of the agency, and it can also serve as a conduit for improvement. So all of that kind of summed up means the whole is greater than the sum of its parts. So ASTHO is going to be putting the results of our field work into a white paper. And the purpose of the white paper is to identify examples of promising practices in state, local, territorial, and tribal collaboration, and to highlight the FAB measures that address those practices. Some of the outcomes that we hope will be seen on the state side or the user side or the reader of the white paper is that the white paper will serve as a model for states, locals, and tribes and territories in collaborative practices. We hope that it will encourage the building of partnerships with traditional and non-traditional partners during accreditation, and we hope that it will highlight creative and innovative practices that can be applied in a variety of settings. So, of course, the overall intended outcome is to assist state health agencies in fulfilling the specific FAB standards and measures through realistic state-based activities. So that's a little bit of a history. Next, we will have Shirley Orr, who is a consultant for ASTHO, share her process of doing an environmental scan of the collaborative partnerships taking place in the field. She'll share with you how ASTHO interviewed staff and gathered information. So without further ado, I give you Shirley Orr. Thank you.
Thank you, Joya, and hi, everyone. Joya, I love your slide that had the photo of the car taken to its many, many parts and pieces. I don't know how many there were there, but there were probably perhaps an equivalent number to the various measures that are part of the FAB framework and all the ways that partners can benefit by collaborating as they move forward with performing those measures. So in the next segment of today's webinar, I'll provide some more background information, including some details about collaboration as a component of the FAB standards and measures. I'll also be describing the outcomes of the interviews that we conducted for this project and some of the main findings, including what we've learned about the importance of collaboration in supporting accreditation by all the partners, including state, local, and tribal health departments. And perhaps most importantly, we'll focus on some of the key strategies for success to improve the overall public health system through collaboration for accreditation. So as you look across the overall framework of FAB standards and measures, you're going to see that collaboration is really woven throughout the entire framework, and it's really present everywhere. In the standards and measures, collaboration's addressed from a couple of different perspectives. First off, collaboration is addressed in the way that we do our work, where collaboration is an essential element in how we perform a particular function or activity. But secondly, collaboration in the work we do is also one of the perspectives that's prominent in the FAB framework. And with collaboration in the work we do, that's where the function or activity performed is in itself a collaboration with public health system partners, including state, local, and tribal health departments. So first off, let's take a look at collaboration in the way we do the work, where it's an element of the way we go about the activities that we undertake. So some examples of this include the major plans that are part of the FAB framework. And in these plans and processes, active engagement by system partners is a very important component of the plan, and then later on the way that that plan is implemented. So these include the plans and processes that are identified here on this slide, such as the state health assessment, the state health improvement plan, the agency strategic plan, its emergency operations plan, the workforce development plan, as well as the QI program plan and the related performance management system. You'll note, however, at the top of the list is the overall process for accreditation preparation. We've learned that states who've organized a formal process where they regularly convene with partners, including local and tribal health departments, they've reaped huge benefits through doing this. Preparation for accreditation together does a number of things, including it illuminates the mutual responsibilities of the partners, it fosters cooperation, and really gives us a way to achieve better quality and efficiency as we all better position our agencies for accreditation. So next, taking a look at collaboration in the work that we do. Collaboration in the work that we do is the basis, as Joya said earlier, for several specific measures in the FAB framework. And today we're going to speak to some that are found in domains 1, 2, 4, 5, 8, 9, and 10. So I'll briefly touch on several of these. I'd like to take the next few minutes to look at some of these specific standards and measures to better understand the role of collaboration in these specific measures. So we're going to get down into the weeds a little bit, but I think you'll find it useful in thinking a bit more about your current processes and practices and how collaboration must be integral in all of those. So first off, in Domain 1, assessment, collaboration in the work we do is woven through the measures that relate to the state health assessment as well as health data sharing that is prominent in this domain. In that second box, collaboration is the specific focus of Measure 1.4.3, which does detail the role of the state health agency in providing support to both tribal and local health departments regarding community data profiles. Here in this measure, the State Health Department documents its collaboration with local and tribal health departments in several ways, by providing data analysis and data presentation tools, also by providing community profiles, and most importantly, by actively engaging with and asking tribal and local health departments about their needs for technical assistance in this area, and then providing or arranging for the provision of that technical assistance to meet those identified needs. Moving ahead to Domain 2, here collaboration is an element that is woven into the work of investigations of communicable diseases and environmental health needs throughout this domain. In the orange box, specifically in this domain, collaboration is the focus of some measures that address the State Health Department's role in providing technical assistance for local and tribal health departments. In this case, the focus of that technical assistance is on outbreak management and on communication during a public health emergency. In performing this TA, state health departments communicate and work with local and tribal health departments through activities like meetings, training sessions, and provision of guidelines or other forms of written assistance to support outbreak management and communication with the public during an outbreak or other type of public health emergency. Domain 4, obviously, is one where collaboration is especially important. That domain is pretty much all about collaboration. Collaboration is the specific focus of Measure 4.1.2, which looks at how the State Health Department provides technical assistance to local and tribal health departments on models for community engagement. And here in this case, the health department at the state level may provide examples of how it provides or assures technical assistance to both local and tribal health departments about some of the models that are available for community engagement as well as processes. Those might include things like MAP, the National Public Health Performance Standards Program, also process tools such as community advisory groups and town hall meetings or forums. Domain 5, policy development. Here, Domain 5 includes the State Health Improvement Plan as well as the agency strategic plan, and certainly collaboration is an important element in both of those processes and documents. Specifically in this domain, however, in that orange box, Measure 5.4.3 details the state role in providing consultation, support, and advice to state and local health departments about the development and testing of emergency operations plans. This is done through a variety of methods, including in-person or virtual meetings, training sessions, and also providing written protocols to partners at the local and tribal levels. Domain 8, the public health workforce. Certainly collaboration is a very essential aspect of assuring that we have a competent and prepared public health workforce. To demonstrate the specific measures in this domain, the State Health Department must have some established relationships with academic partners to assure that there is an adequate pipeline of new workers to enter the field of public health. This might happen through activities including practicums, internships, guest lectures provided, and also joint appointments of faculty and State Health Department personnel. In this domain, another measure where collaboration is the focus, an expectation that State Health Departments share their knowledge about workforce capacity assessment, workforce training, as well as continuing education, sharing that with tribal and local health departments to help to address workforce gaps. Moving on in Domain 9, collaboration is a specific focus in Measure 9.1.6. And this measure looks at how the State Health Department provides support, again, to tribal and local health departments, this time for performance management. Here, collaboration is key to support local capacity as well as to promote better alignment between state, local, and tribal work in measuring performance as well as documenting outcomes. Again, in this measure, the efforts of the State Health Department are demonstrated through provision of training and also group or individual technical assistance, this time about performance management. And finally, in Domain 10, there are multiple collaborations which are needed to meet the standards here. State health departments must demonstrate collaboration first with academic partners or research institutes to begin to connect the evidence base to practice across all levels. In this set of measures as well, state health departments must demonstrate collaboration with local and tribal health departments and provide them with technical assistance so that they might be better prepared to apply research to their practice. As Joya shared earlier, this ASTHO project for collaboration and accreditation preparation was informed by a series of interviews with 20 state health departments. These took place over the last several months. We heard from a selection of states with varying geographies, populations, also organizational structures. We heard many great stories that illustrated the degree to which states were collaborating and the degree to which that collaboration is critical, not only as a component of specific standards and measures, as we've just discussed, but perhaps more importantly, the value of collaboration in the overall process of preparing for accreditation through state, local, and tribal combined accreditation work groups, councils, or committees. These are often convened by the State Health Department or by any number of the primary partners. In the interviews, we learned of several effective collaborative strategies that are currently underway for accreditation preparation. As I just mentioned, the creation and regular convening of accreditation work groups, alliances, or learning collaboratives that reach out and include the state, the local, as well as the tribal health departments and other partners as appropriate has proven to be very valuable. And you'll hear that as a consistent theme echoed today through the case examples you're going to hear from our 3 states. One of the common activities conducted by these work groups is a joint review of standards, where the partners jointly review standards and measures in one or more domains during a series of meetings. This practice has proven to be a very effective strategy used in several states to promote a better understanding of the mutual roles and responsibilities that partners have in supporting accreditation for all. Also, the designation of specific state health department staff who have roles including serving as liaison with local and tribal health departments for accreditation has been very useful. Later in the session also you'll hear more about how this strategy was implemented in the 3 states who are sharing their experiences today. The creation of a shared electronic workspace for accreditation is also a common strategy that's been implemented in many states. And this has provided an accessible way for all the partners to communicate about their progress in accreditation, as well as to collaborate in the development and sharing of documentation for accreditation. And finally, in addition to the shared electronic workspace, other useful tools have included things such as accreditation-related newsletters, web pages, and listservs. Many state health departments have also leveraged other existing communication tools that are used in their agencies and also provided by their partner organizations to disseminate information and resources related to accreditation to their system partners. Obviously, in order for collaborations for accreditation to be truly effective, a wide range of partners must be engaged in these processes. In addition to the state, local, and tribal health departments, some other key partners to involve include, first off, the SHOs, the associations that represent local health departments in your state. In addition, SALBOs, or associations of local boards of health where they exist, can be very valuable partners in engaging Board of Health members in the accreditation process. Also important are state public health associations, the affiliate organizations of the American Public Health Association. These associations typically hold at least one or more statewide public health meetings each year. These are really excellent venues for topics related to quality improvement, performance management, and accreditation readiness. So working with those partners at the Public Health Association to incorporate those topics as a consistent theme on state public health association meeting agendas is a very promising practice. Another vital partnership involves academic partners, including schools of health that sponsor the public health training centers. These partners are very important in creating coordinated workforce development plans, also in ongoing efforts to assess workforce competency and in implementing training that meets the identified gaps. And finally, the public health institutes. You'll hear today from our presenters about the role that they've provided in a wide range of activities that support public health standards and accreditation. The basic message, the most important thing, I think, from the interviews is very clear, and that's that a collaborative process that includes the regular convening of state, local, tribal health department partners is an essential element to achieve success of all in achieving accreditation, and also helping to make accreditation the most meaningful and effective process in improving the health of our population and the work that we do every day. At this point, we'd like to turn and hear more from the three state partners about how collaboration supports their accreditation efforts in their individual states.
Great. Thank you, Shirley, and thank you, Joya, as well, for that history and background. So I'm going to turn it over to Rebecca and Angela in Wisconsin. So go ahead.
Hi, this is Rebecca Cohen, and we would like to just thank ASTHO again for the opportunity to share our collaborative work here in Wisconsin.
And this is Angela. We also want to acknowledge other Wisconsin Division of Public Health staff and the Wisconsin tribes and our other partner agencies we'll be mentioning. Specifically, we want to acknowledge the collaborative work with the Institute for Wisconsin's Health, Inc., and other staff in DPH. It's been instrumental in the building of our local partnerships that we'll discuss today towards accreditation readiness and quality improvement institutionalization.
Well, I'd like to just briefly provide a background of our state government here in Wisconsin. Our Wisconsin Division of Public Health has about 6,000 staff across 7 divisions. I mean, our Department of Health Services has about 6,000 staff across 7 divisions. And the Division of Public Health is one of 6, has about 6 bureaus and offices and approximately 400 employees. The Division of Public Health is comprised, as you can see from the map, of 5 areas. And we are a decentralized state here in public health, but that really is important to note that we are comprised of 88 locally controlled health departments. And mainly, these are county-based health departments. and we have 11 tribal health departments. The highlights of our work in Wisconsin now are through the Wisconsin Public Health Improvement Initiative, and we're working towards accreditation and accreditation readiness, which really is a strong link with our local and tribal health departments across the state. Wisconsin was involved early on with the multi-state learning collaborative work and one of the 16 states, which was funded by the Robert Wood Johnson. And in Wisconsin, the early program was called Wisconsin's Public Health Quality Improvement Initiative. And now this work has been supported through the CDC NIFI. Our public health funding flows through the Division of Public Health as the lead agency, and it is now the driver for funding for the Wisconsin Public Health Improvement Initiative. Wisconsin has 11 American Indian tribes, and the number of American Indians living in Wisconsin varies. But according to the latest Department of Administration report, there are approximately 70,000 American Indians, making up about 1.29% of the population. Of note is that each tribe is a sovereign nation with its own government and constitution. Each enrolled tribal member has citizenship with their tribe within the state of Wisconsin and the U.S. I'd like to also say that Wisconsin has seen an increase in our American Indian population over the last decade. One tribe that has been involved from our very beginning efforts toward accreditation and accreditation readiness has been the Forest County Potawatomi tribe. And it was the first tribal health department to join in the multi-state learning collaborative. Our beginnings with our tribal work go back to July of 2011, where we had a 2-day training, and it was attended by 4 of the 11 tribes, including Ho-Chunk, Lac du Flambeau, and Oneida Nation, in addition to Forest County Potawatomi. And I'd like to say also that all of the 11 tribes have been participating in our meetings or forums to some degree, and there are varying levels of participation in the work that we are doing. I'd also like to note that in working towards accreditation, the leader, Forest County Potawatomi, as well as the Ho-Chunk Nation, are close to submitting their letters of intent for accreditation to the FAB board. Within the Division of Public Health, our main Office of Policy and Practice Alignment is the institutional home for the State Health Plan, Healthiest Wisconsin 2020. The State Health Plan is required every 10 years by state statute. In our work to develop our State Health Plan, the focus area under public health capacity and quality had 2 notable goals. And one of the goals by 2020, which this says that all Wisconsin health departments will be accredited, and again, using an established standard. The other goal that is of note is that by 2020, all Wisconsin health departments will implement established quality improvement processes in daily practice. Collaboration is building sustainability here in Wisconsin. One of the early commitments made by the division and underlying almost all of our projects is the idea of spreading or sharing resources. The public health system is really fortunate to receive abundant resources, so we have been fortunate to be able to practice what we preach. And over the past 3 years of the CDC funding, going to the Wisconsin Public Health Initiative, almost 1/3 has gone out to local and tribal health departments to support their journey on accreditation. I'd like to say also that this has been awarded through a competitive process. And also these competitive grants going to the local and tribal health departments are being funded at anywhere between $3,000 to as high as $15,000, depending on their grant applications. We've also funded some special targeted projects as well. The WIFI funding, or CDC funding, is about 15% funding our DPH staff, or Division of Public Health staff, in our 5 regions. And it is critical that we note that the work in our regional offices is supporting our accreditation efforts through working with our local and tribal health agencies. We also have been encouraging through QI training, as we have our leaders, to encourage them to share their time, and they also have been very willing to provide consultation and in sharing their documents and resources with other locals and tribal health departments.
The activities of the Division of Public Health have supported the local and tribal partners. We've sought experts to provide lots of web-based trainings and meaningful community of practice forums in each of the 5 regions that are attended by the local and tribal health directors and their staff who are working with them on accreditation readiness. That's allowed some networking and interaction around quality improvement, performance management being done. We have established in the regional offices what we refer to as radar teams. Those are regional assessment, policy development, assurance, and response teams. Those, you'll recognize the name from the nationally recognized core functions of public health. And the regional offices really are charged with providing leadership for a strong, cohesive state public health system. One of those ways is these communities of practice that really are working on focusing on building a community, enabling interaction and discussion and collaborative activities and relationships around this common interest of accreditation and public health improvement, then sharing the practices, tools, stories, and problem solving that they've used to move ahead in that journey. I mentioned earlier the Institute for Wisconsin's Health, Inc. A portion of the CDC funding that we get does support the Institute, and through their leadership they've provided very strong training and consultation to the local, tribal, as well as state staff in Wisconsin. We've also funded the University of Wisconsin a bit to support performance measurement and an integrated QI project. We've partnered with their NIATEX program, which is in their Center for Health Enhancement Systems at UW-Madison. That provides a QI tool to support training and integration of QI into local and tribal health departments, and that's available through the Wisconsin Train Network online training in modules that are accessible to everyone remotely. In building connections, our contract partner agency, the Institute, in focusing on our relationships with the tribes, has led several quarterly tribal forums. They've facilitated and worked with the Division of Public Health staff, as well as the partners from the tribal communities, in identifying agenda topics to cover. They're most often framed around specific FAB domains or the prerequisite documents, and they've been very well attended, and participation by the tribal community health staff has been increasing over the last couple of years. The Institute is also engaged in another effort through Robert Wood Johnson funds with Red Star Innovations. Folks may be familiar with Alina Hernandez's work, and their future work on forums to share between tribal health departments and state health departments. That's going to be going on in some pilot states. Wisconsin is one, and I believe California and Arizona are also in that effort. I mentioned earlier the tribal staff are working with QI and accreditation training. We have consultation funding to partner with the Institute and their trainers and presenters. They can also contract specifically with the Institute or others to assist with QI plan development, performance planning, and other consultation services. We've done multiple webinars on QI and performance management topics, and those are archived and available remotely, and to not just those that have received the specific funding, but statewide and through our webpage links. We found some very strong local sustainability supports in these building blocks, and it's just the initial relationships that we've had through the regional offices to the staff working in the tribes in supporting their programs has really paid off in this new venture towards accreditation preparation. The frequent communication, collaboration. We've been working to support our project goals, but also always having in mind their project goals and work towards our statewide accreditation readiness. The accreditation and QI team efforts at the tribes has been strong in their efforts. Many of them are accredited by AAAHC in their clinical side or JACO clinical accreditation, and we've been working with them to support some of the ties between public health accreditation and leveraging the needs, the requirements they've already met through their clinical accreditation towards the public health accreditation. We've worked through some unique situations and issues that come up when you're dealing with tribes in governance and laws, the tribal sovereignty being tribal nations, not similar to our counties and city health departments, but being unique entities and recognizing that and the dynamics in the government-to-government relationship there. And also working with them because many, as you may have seen on the map earlier, are on small land bases within counties that we work with, and so helping facilitate some of the collaborations between the local county health department that serves a common population base has also been an area of focus with that. Some of our successes has been these forums and communities of practice specific to the tribal community health programs and facilitating their sharing of the documents and ideas and problem solving, sharing how they've supported their workforce in moving towards accreditation and integration of performance management and quality improvement into their work. They have developed strong motivation and commitment to improving and strong community health programs. They're linking in with other initiatives addressing health disparities, their QI work within the clinics, and strategic goal alignment with our state health plan and other links that they may have within their communities. So with our lessons, listening has been critical, relationships have been critical, using a framework, a long-term timeline to build the relationships, and recognizing the differences and the varied cultures, not just the tribal cultures, but the organizational cultures that we all live and work within, respecting the different perspectives, and being consistent and thoughtful in our communication and meetings, and building that respect and nurturing the relationships, I think, have been the strength in our communities. So that's Wisconsin's story with our tribes.
Great. Thank you so much, Rebecca and Angela. So next on the agenda, we're going to turn it over to Luann, who is in Minnesota. So go ahead, Luann.
Thank you, Denise, and thank you to ASTHO for the invitation. Good afternoon, everyone. I'm really happy to be here with you today to describe Minnesota's public health collaborative system and how it has assisted us in helping them meet the standards and measures. First, a quick look at Minnesota. We have a population of 5.4, a lot of population in the metro, but also vast rural areas. We also are decentralized, and we have 13 tribal nations. We have 87 counties, and they are organized into 50 jurisdictions, 50 community health boards that might be made up of anywhere from 2 to 5 counties. Our system in Minnesota is governed by a state statute that has been in place since 1976, and it's only been minorly revised along the way. So it has served us very well as we work collaboratively. The statute 145A outlines the structure and responsibilities of locals and the state within this partnership, and we really do view this as a strong partnership. The goal is the provision of public health services throughout Minnesota. So a key component of the statute is written here, and it is the State Community Health Services Advisory Committee. It is a committee that advises the Commissioner of Health and provides guidance on the development, maintenance, financing, and evaluation of community health services within Minnesota. This committee, which we call SHDS, has 50 voting members. About 2/3 of the voting members are local elected officials, the county commissioners and that sort. And then about 1/3 of the members are local public health directors and community health services administrators. Regularly, the members come together face-to-face in face-to-face meetings to deal with public health issues and to set priorities for the issues and for the work of the coming year. But in order to complete that work on the priorities, they develop work groups so that members of the SHDS committee will volunteer to be on the work groups to deal with the issues. So back in 2009 or 10, a big concern, a big priority in Minnesota was identified, and a work group was formed to look at accreditation and performance improvement. So for over a year, this group met and discussed and developed our roadmap for improving our public health system in Minnesota. So this report was written at the end of that work group, and as you can see here in the quote, the report is on the left. The quote, the essence of the whole work group can be crystallized in the quote: the state-local partnership should act collaboratively and systematically to improve performance and thereby facilitate achieving the national standards. So on the right is a list of some of the recommendations. This work group came up with a number of recommendations, but these are the ones that are key to the work that we're talking about today. The work group decided that the standards were good and achieving the standards would improve performance in Minnesota. They also recommended that Minnesota should make changes to their existing systems to align with the standards. This And so they also recommended that MDH should lead the way and seek accreditation by 2013. And we are on that journey right now in Minnesota. They recommended that MDH and CHBs should work together so that the CHBs are prepared, the community health boards are prepared to apply for voluntary national accreditation by 2015. So the work group developed or initiated a steering committee, the Performance Improvement Steering Committee, to oversee these recommendations. Their responsibility is, and they are meeting monthly, and they have been meeting for a number of years, and the committee is made up of 10 representatives from 10 community health boards, 1 tribe, 3 Minnesota Department of Health employees, and 3 Office of Performance Improvement staff members also, which are also MDH employees. So their responsibility was to oversee this alignment of the local public health assessment and planning process and align it with the national standards. It was also to oversee implementation of our NIFI funds and our NIFI activities to build performance management infrastructure and capacity in Minnesota. And it was to identify opportunities for performance improvement and strategies. What this Performance Improvement Steering Committee did over the years was develop our framework for performance management. It is that to the right, which as you can see is based on the Turning Point framework. We also identified, we have a reporting system every year that the locals report back to the state, and we took a number of the FAB standards and used them as performance measures, which we will check every year. And then so now the data from that, from those performance measures we have the first year's data, and from that we can choose our improvements along the way. In the summer of 2011, we used NIFI funding to give to the community health boards and tribes to complete a self-assessment of the FAB standards. We did this as an introduction of the standards to them, as well as the goals listed here, which is to assist them to assess their own capacity, the tribes and the CHBs to assess their own capacity to meet the standards. And also it enabled Minnesota Department of Health to obtain valuable information about needs that they may have as far as technical assistance, to give a baseline of how they felt about how they could meet the standards and what they needed to improve. So this project as a whole allowed us to analyze the community health boards and see how they were doing as they worked towards accreditation. It allowed the locals to identify ways to improve them working together as a CHB, a community health board. Some of the community health boards are only 1 county, and other community health boards are anywhere from 2 to 5 counties. So the ones that had to work together, this enabled them to figure out ways that they could do that best. And it also allowed them and us to collect information useful in the future for public health strategic planning. In the end, 40 out of 50 community health boards and 1 tribe participated in the standards assessment project and received some funds from NIFI. We did analyze the results, and as you can see, the grid on the left is single county, single tribe, single city community health boards, and the one on the right is multi-county community health boards. And we just kind of analyzed the results, where their need was, where it was identified the most. And as you can see, standards 1, 5, 8, and 9 were most significantly listed by our participants. So they told us in this way and in other parts of the survey that we did give them that they wanted assistance in developing a strategic plan. Most of them had never done this. They wanted assistance in developing a community assessment improvement plan and QI plan that met the national standards. We had a system in place that we had them do a community assessment and improvement plan, but we wanted to make sure that all was aligned with FAB. And then they also wanted support for their accreditation coordinators. They wanted things like crosswalks of state and local plans and FAB measures, and wanted help in document selection and things like that. So beginning in the fall of 2011 then, we started working on following up on some of these needs. So MDH, the Office of Performance Improvement, began offering one-on-one strategic planning facilitation services to the CHBs and tribes. How did we do that? Well, we got an external consultant to sit down with the district public health nurse consultants and work through what it would look like to facilitate the locals in a strategic plan that met the standards. We have 6 public health nurse consultants that are distributed throughout the state. And they and a few central staff from St. Paul here were trained then by the external consultants to deliver step-by-step this one-on-one facilitation. We have piloted this twice. Well, we piloted it twice as we were developing it. One with a single county CHP and another one with multi-county CHP. Got input from that, went back and improved the facilitation process even more, and began this project, like I said, in the fall of 2011. And we are prepared to go community health board by tribe, by community health board, to get this accomplished by the deadline of early 2015, which is our regular 5-year cycle of assessment and planning in Minnesota. Like I said, they also wanted support for the accreditation coordinators. So the district public health nurse consultants developed a monthly accreditation coordinator support conference call. They worked along with the people participating and identified the topics that the locals wanted included in it. And some of the just examples of some of the things they really wanted at the granular level was position description of accreditation, documentation guidance, process of the timeline, prerequisites, resources, and of course what kind of technical assistance MDH could give them. The nurse consultants also held regional documentation trainings also, and which was a real hands-on looking at a piece of documentation. How do you judge whether it's good or not? How you look at the measures and decide what kind of document you want. This cohort ended naturally when they felt they had gotten enough from this process, and we will start a new one at the end of this year. Back to this slide again, I just wanted to mention that we did say that we added FAB measures to our performance measures, our reporting that we do every year. And the data from that we will use and have used and will use to judge our future technical assistance. So this past year, 2012, this is the information that they identified. These were 35 measures that we identified and then we asked them in our reporting system whether they fully or partially met these national standards. So as you can see, as you wander over to the right side of the graph, the areas where they really still want and need technical assistance, and that's what we'll focus on. And this will change every year, so our focus may change every year also. In Minnesota, we have a small number of counties that are actively pursuing accreditation or have applied for accreditation. But the collaborative work that we've done since 2009, we feel that we've really accomplished a lot. By collaborating, Minnesota will have achieved the following results by 2015, and that is that all our CHBs will have engaged in an assessment and planning process that is required by state statute here in Minnesota, but is also completely aligned with the FAB standards. So that means they will have their prerequisites done by that time, and along with a QI plan also here. And many CHBs, in addition, will have hands-on experience of documentation, identification, and collection. There's always lots of challenges along the way, of course, but one that I have to say we met head-on right away was that local budgetary restraints make accreditation not always a seemingly viable or popular topic because of all the workforce issues and just budgetary restraints. So we decided to really focus the energy and discussion on meeting the FAB standards, the standards and measures. As you remember, the Performance Improvement Steering Committee identified early on that the standards were good and that they were worth pursuing because they would improve performance in Minnesota. So we realize that accreditation is a local decision, but we all agree that meeting the standards is well worth pursuing. Thank you.
Great. Thank you so much, Luann, for sharing Minnesota's story. And our last state to present is New Jersey, and we have Natalie on the line. So Natalie, take it away.
Thanks, Denise, and thanks, ASTHO, and thanks to everybody who's on the call today. Very much enjoyed hearing the stories from the two states that preceded. Very interesting lessons learned. I'd like to share our lessons learned over the course of the past 10 years with you and frame it in using the analogy of building a brick wall. But just a little bit about New Jersey. We have a lot of little towns, 561 towns organized into 21 counties. We have nearly 9 million people living in 7,300 square miles. I think New Jersey is the most densely populated state in the U.S. Even so, we have only 95 health departments. There are 21 county health departments, and then the remainder are organized either in single towns or multi-towns. And their sources of funding are primarily federal flow-through or local realty transfer tax. And if I say the word or the phrase home rule, I'm sure many of you will understand what I'm saying when I say that New Jersey is definitely a home rule state. And because I'm a New Jersey girl, I just wanted to share with you some images of New Jersey. Many of you probably think of New Jersey in terms of the two top images, which are up by the Newark area, the Turnpike, and the refineries, but there's also the shore, the southern areas, which are farmlands, the northern areas, which are very hilly and lovely and lots of streams and a lot of greenery. So New Jersey is a very diverse state, both in terms of its geography as well as in terms of its population. So the one thing I learned from graduate school when I was working full-time, going to school full-time, and also raising a family, is that everything that I did had to have multiple applications. And I've taken that lesson learned from my own personal life and applied it in the work that I've done in New Jersey with my colleagues at the state level and at the local level, that every initiative that we had needed to fulfill multiple purposes so that we could get the most out of it and build on existing efforts so that nothing was lost or gone to waste. So the first piece of this brick wall, if you will, actually was laid, or rather the foundation was laid in 2003. I don't think that the writers of our regulations for public health at that time realized that they were quite prescient in that they rewrote the regulations that pertain to how public health and local health departments undertook their business. They aligned them with the 10 essential public health services, including, among other things, having a CHIP, having a QI plan. And those rules are grounded in our statutes as well and very much determine how public health practices in New Jersey. In the meantime, many of you are aware that the NACCHO operational definition of a local health department was defined or scoped out. There were various discussions on the national level about should we or should we not go down the route of accreditation. And in the meantime, I was curious to know whether our practice standards, our regulations for public health, and the NACCHO operational definition, whether there was a good crosswalk. And when I took a look at our standards and the operational definition, there was a practically 90% goodness of fit. At that time in 2008, what we started to do was to audit our 95 health departments to see whether they were meeting the practice standards. And the reason we waited for a little while, in other words, we didn't start in 2003, is that the new regulations were such a departure from what had been in place earlier. Health departments need a little time to get on board. But what we discovered when we did conduct the audits, and by this year we've audited about half of all health departments, is that the majority of them do meet the requirements of our practice standards, which are grounded in the 10 essential public health services, which inform the FAB standards. And our takeaway is that if the health department is following our guidelines or our practice standards, then they're very well positioned to start to prepare for accreditation. The second piece of our building block, or our brick wall, is to actually lay the bricks. So by 2007, what we've discovered is that every single health department in New Jersey has a community health improvement plan. After that, New Jersey, after a few earlier attempts, actually did become a member of the MLC3 community. And as a result of that generous funding, we were able to extend in-depth QI training to about 40% of all local health departments in New Jersey. That was huge because that was something that we had not been able to offer earlier. Shortly afterwards, our academic partner, the School of Public Health, received a grant to become the New Jersey Public Health Training Center. So other gaps that we had not been able to address in our work statewide in workforce development, for example, Domain 8 in particular was their focus, were able to be addressed through that grant funding. And then in 2011, New Jersey was also awarded a NIFI grant where we undertook additional QI training. Actually, it was more performance management for the remaining 36 or some odd health departments. So now what we've done is we've covered the waterfront, so to speak, in terms of QI training, community health improvement planning, and performance management. And then the final piece of this particular puzzle is that our New Jersey SHO, which had been I should also say that in all of this work, it's not just the New Jersey State Health Department, but it's our New Jersey SHO and our academic partner, the School of Public Health, that are working on this as a tripartite effort. Finally, in 2012, our SHO takes the leadership role again and launches training for health departments in strategic planning and having a strategic plan for their organizations. And to date, about 20 local health departments have both been trained and have a strategic plan for their organization. So we've been building on the capacity that's been developed both at the MLC3. The MLC3 partners did not lose any of the capacity. That was folded into the New Jersey Public Health Training Center, into the NIFI work, and into the SHO training. So everything was multi-purposed. We built on, for example, the performance management training that was allowed through the NIFI grant is now being converted into an online certificate program for health departments in New Jersey. It will be made available around the country, but for us it's particularly significant in that we can offer continuing education credits for our public health folks who require them in state. Finally, filling in the gaps. So you have to have mortar to keep the brick wall together. And for us, this is escalating all of this work, all of this capacity building, all of this laying of the foundation and setting up the brickwork to actually move to the final end state, which is getting health departments to accreditation. So last year, I conducted a survey and discovered that 22 health departments are interested in preparing to apply for accreditation. So based on that, again, the three partners, the State Health Department, the State SHO, and our School of Public Health created an Accreditation Readiness Committee. And this October, we'll have a kickoff for not just those 22 health departments. It will be open to everyone. But the purpose of that kickoff meeting will be to create a accreditation learning cohort, which we will then work with to bring them to the point of actually submitting the letter of intent to FAB. I should say that while I have been working with my colleagues and the partners statewide on local health department accreditation readiness, the State Health Department itself has also been preparing for accreditation. I'm a member of the QI team that's leading the QI effort at the State Health Department, as well as a member of the team driving the accreditation of the State Health Department forward. So the commitment to supporting those local health departments who want to achieve accreditation and this very public recognition of excellence in public health is something that our office and our State Health Department is very much committed to. and we're very excited about seeing this through to the next level and having at least as many health departments that have indicated preparedness last year apply by 2015. And that is the end of my presentation. Denise?
Great. Thank you so much, Natalie, and thank you to all the presenters. That was a very, very terrific presentation. So at this time, Chris, if you could open up the lines for questions, that would be great.
Certainly. And ladies and gentlemen as well, if you would like to ask a question using the chat feature, you may do so. It's located in the lower left corner of your screen. And ladies and gentlemen on the phone lines, if you would like to register a question at this time, please press the 1 followed by the 4 on your telephone. You will hear a 3-tone prompt to acknowledge your request. If your question has been answered and would like to withdraw your registration, please press the 1 followed by the 3. And if you're using a speakerphone, please lift your handset before entering your request. One moment please for the first audio question.
Thank you, Chris. So while we're waiting for those questions from the audience, I do have a couple of questions through our chat function. This question is for Minnesota and New Jersey. Can you talk about how you're handling staff turnover at the local level and your issues related to maintaining your momentum through having a high staff turnover?
This is Luann in Minnesota, and that's obviously a huge challenge. In addition to staff turnover in general, I'm sure many of you are also appreciating the fact that retirements are running rampant, and that's even more difficult to deal with. So how we deal with that the directors retiring or leaving in general is that our state is divided into regions, and the regions have a district public health nurse consultant who work one-on-one with them basically, and so they are in charge of overall orientation of new directors and their staff if they wish to have us involved with their staff. So it's the same thing that happens with everything else in public health. It's the same thing with accreditation. We really just can only deal with it on this this personal one-on-one orientation and helping them through with the help of the district nurse consultants.
This is Natalie from New Jersey. In terms of accreditation preparation, we try to offer as much assistance as we can in a hands-on method. But if you go up to the 30,000-foot level, because that is an issue here as well, both staff turnover and retirement, is that there's been an increased move to regionalization and a look at sharing of resources. 2, what we've found is that public health has had to retrench. In other words, draw the line a little bit more tightly around what it takes on and what it considers to be core public health in New Jersey, and focusing in on those things that governmental public health does, perhaps that no one else does.
Mm-hmm.
Great, thanks. Thank you, Natalie and Rebecca. Luann, are you all having the same issues in? Oh, I'm sorry. I directed that at Minnesota and New Jersey. So I left off Wisconsin. So Wisconsin, do you want to, Rebecca and Angela, do you want to speak to this? Are you guys seeing the same issues?
We are definitely seeing the same issues, and I think trying creative ways to keep things moving, and like I mentioned, virtual online training availability and building it into orientations that to kind of reinforce, and hopefully we're building that culture so that when new employees do come in, they're just ingrained in it, that it's not something that needs to be kind of force-driven, but just the way the organization operates now. So we're not there yet, but we're working towards that.
Great, thanks, guys. So, Chris, do we have any questions from the audience?
No questions on the phone lines at this time. However, ladies and gentlemen, as a reminder, to register for an audio question, please press the 1 followed by the 4. Thank you.
Okay, so we heard all 3 states talk about kind of the challenges and lessons learned. So I wonder if you all could speak to maybe a particular challenge that has come up and that was really it was a really difficult challenge to address, and how did you address that challenge? So can we start maybe with Natalie in New Jersey?
Yeah, sure. The work of both quality improvement training, of performance management, all of these initiatives that all 3 states have discussed, all require a facilitation, which means a warm body that's dedicated to moving the process forward, whether it's on the state level, at the local health department, or more regionally available. We find when those resources are not in place and individuals, and we understand that the health departments, they're all working on, and right now accreditation preparation feels like an add-on, and it's not embedded in the culture, as was just mentioned. It's not an automatic part of our doing business. So right now we do need a lot of that facilitation. So for us, an ongoing challenge is finding the resources to underwrite the facilitation that is oh so necessary in assisting the local health departments and our own health department in continuing to drive the process forward. We're very grateful to the CDC, to HPP, to ASPR, and those various funding sources for their ongoing commitment. So it's very important for ASTHO for continuing to lobbying for those resources. So that's for us a major ongoing issue with no easy fix. But I'm hoping, as was said, once all of these practices are embedded in organizational culture, it will become less of an issue.
Great, thanks, Natalie. Angela and Rebecca in Wisconsin.
Hi. Well, I was going to just echo what Natalie had just said about the concern about the resources, because Wisconsin is one of the lower, we're nearly at the bottom of public support, state funding for public health. So that means that the grant funding that does come to our state does become critical, and that by having our mini grants be competitive, it is always the question: are we going to have more resources? Is there going to be more funding? So that's where the sharing and the collaboration becomes key to being successful here in Wisconsin. But Angela has another area of focus as well.
Well, yeah, and that being that the state has had a long-standing, probably 10, 25 years of administrative rule, what we refer to 140, which is putting into practice assessing each of the 88 local health departments for providing a minimal level of services and rating them as minimal at level 1, level 2, or level 3 for health departments that's providing a broader range of services. And those assessments we are in statute to conduct every 5 years, and they're framed around the 10 essential public health services. And so we've been doing those. The next round is scheduled to be done in 2014. And now we have 3 health local health departments that have achieved accreditation and several more that are very close to achieving that. And so by them needing to meet our state requirements for this Administrative Rule 140 review, as well as the accreditation requirements, they're feeling, doubly burdened. So we've been working very diligently this year to closer align our requirements for the 140 review and documentation to the FAB requirements. So as those agencies that are striving for national accreditation are not penalized, and doubly those that are not striving for accreditation don't feel the need to become accredited or to meet all of the standards that FAB sets forth. They often are the smaller health departments that are sharing resources across their jurisdictions that someone else also mentioned there. So that alignment with our state process and the national standards has been sort of a key focus for us as well.
Great, thanks, guys. Luann, anything to add from Minnesota's perspective?
Yeah, and I'm just repeating myself actually, but the big challenge we had initially and continues is basically the political will based on budgeting restraints within the state at the local level. And as I described, our structure of policymaking is just based on wanting and having elected officials involved in the whole process. So we have the added responsibility of educating them on public health. They have a lot of other issues they're dealing with too, and budget restraints in those areas too. So we really have to actively, constantly educate them on public health and the value of something like supporting something like accreditation. So it's been a challenge for us, but we keep plugging away. And then again, reiterating what the other speakers said, those issues are definitely in Minnesota also.
Great. All right, great, thank you. So I'm going to go back to Chris. Chris, do we have any questions from the audience?
No questions on the phone lines at this time.
All right, so I'll continue to use the chat questions. And I guess this question can, if all three states could address this question, can you talk a little bit about maybe key staff that were involved in establishing some of these partnerships and collaboratives in your state, if any? And who those key staff were, and maybe talk to us a little bit about how they started the journey. So how about Luann? Do you mind if I ask you to go first?
Sure. There's been many people involved along the way, as you can see with our work groups and so forth. But when it comes to getting basically in the faces of the local health department directors or the community health board directors, our system of having the district nurse consultants who we call generalists. They're not maternal. They don't deal with maternal child health. They deal with or any specifics. They deal with the needs of the directors and how they work in public health, and so they're generalists. And so if they weren't on the ground walking our community health boards through some of this, I think we would not be as effective in a lot of our initiatives. So I'd have to say them.
Denise, this is Natalie from New Jersey.
Sure, go ahead.
So from the State Health Department, it's been our office and typically just me. But from the side of the SHO, there have been 2 or 3 key health officers who have been absolute champions for this, and I can't underscore how important that's been. And so we don't actually have dedicated staff here. nor do the SHO have a dedicated staff. And on the side of the School of Public Health, we have some very, very committed champions as well who have stayed the course for the past decade. So I think it's less for us about staff than it is about having key champions in each one of these key partner areas. And it certainly helps that our commissioner and the dean of the School of Public Health are very much on board with all of these efforts and are very upfront about that.
Great. Thank you, Natalie.
Hi, this is Rebecca, and I would say that the champions from the early get-go were, I have to kind of echo what Natalie said, were our state health officers, that they were some of their champions and some of the leaders with the local health officers. And on the state side, we had some regional office directors that really were also working nationally with some of the committees and some of the associations that really brought back that energy and that motivation, and I would say that vision, that this is really important, this is really vital, and that this is the direction in the future that Wisconsin should be going. And they painted that future, and I think, we're striving to go there. That's our journey. But I think that was the key, was we had strong support from, and also our relationship with the university as well. We've had some key champions over there as well.
Great, thanks so much. I'm going to go back to Chris. We have about another minute left. So, Chris, any questions from the audience that are on the phone?
No, there are no questions on the phone lines at this particular time.
Okay, great, thank you. So I guess in our last minute, and I am going to put the presenters on the spot, any kind of high-level burning thoughts that you might have? I guess it's really more of a advice that you would give to states as they go through the accreditation process and as they work with the various partners at the state, local, tribal level, the SHOs, the public health institutes, et cetera. Any last words of advice for the states?
This is Natalie. I don't think I'm telling anyone anything that they don't know, but all the rules in the world cannot replace goodwill. So having that goodwill and intent to collaborate for a greater purpose has been the underpinning for much of what we do, and I'm very grateful that we have that goodwill in place.
Thank you. That's very good advice. So, Angela, Rebecca, or Luann?
Hi, this is Angela, and I think part of it was you leveraging the relationships, finding who already has established relationships, be it with the tribes or with the Institute of Wisconsin's Health, and using those, nurturing those, and giving it time, giving it attention and giving it time, and not feeling like you're behind the game, that you're taking it at your own pace, but you are focusing and nurturing it, not neglecting it. But it will come in time if you find the right angle and give it the right devotion.
Great, thank you. Any other last words of advice from our panelists?
This is Shirley, and I'd just like to share a comment that I'd heard during the interviews that I thought was really poignant. One of the interviewees said that in all that they did, it was before them all the time, and always the driving force was the thought of doing things that are ruthlessly practical. And I think that, especially given all the constraints that we've heard echoed today from the 3 states. I think assuring that in all we do that it's very directive, very practical, and that it has an immediate benefit and outcome. Start where you are and do those things that can demonstrate some very immediate short-term gains for everyone while working toward big picture long-term gains in the long run.
Great. Thanks for sharing that, Shirley. So we are out of time, so we'll need to conclude our webinar. Once again, want to thank our presenters, our funders, and of course our participants for being present for this webinar. If you are in need of further information about collaboration or other topics related to accreditation and QI, you can contact me at the email address listed on this final slide. And once again, we value your feedback, so please take a moment to provide us with your feedback on today's webinar. And once you close out of the webinar, you will receive that link. And thank you, and that concludes today's session. I hope everyone has a great day.